So. Good evening, everybody. I'm going to invite everyone to take a seat, and we're going to go ahead and begin the program. I'm Rabbi Michael Danziger, and it is my pleasure to welcome you to the temple. We are honored to have the chance to host this second of 3 installments in our collaborative community partnership on abortion and Jewish law. A month ago, we learned with an array of our community's clergy. Tonight, it's the medical professionals to share insights on what it is to practice in the reproductive space. And we're very thankful to all of the synagogues, agencies, and institutions that are partnering to make this possible. Chief among them, the Jewish Community Relations, JCRC, and I'm going to hand it over now to our Community Relations Director from the Federation, Deborah Olshansky, who will take us into our evening. Welcome, everyone.
Thank you. Thank you so much. And thank you all for joining us here this evening. We are very fortunate to have a panel of 3 expert physicians. I will introduce them briefly, and then we will get right into questions. We will also take questions from the audience. If you have a question at some point, if you'll raise your hand, Judy will bring the cards and pens around, and they'll be brought up to me. So we will work in as many of the questions as possible. We welcome both those of you that are here in person and those of you that are joining us virtually. And we know this will be a very important and informative evening. Dr. Frank Bohm is Professor Emeritus in the Department of OBGYN at Vanderbilt University Medical Center, where he served for 47 years on the faculty as Director of Maternal Fetal Medicine, Vice Chair of the Department of OBGYN, Chair of the Medical Center Ethics Committee, and Chair of the Abortion Committee for 45 years. He's married to Julie and has 3 children. Dr. Nancy Lipsitz. Dr. Nancy Lipsitz works as an assistant professor of obstetrics and gynecology at Vanderbilt for 9 years. Dr. Lipsitz is the current chief of the OBGYN department at St. Thomas Midtown Hospital and has previously served on the ethics committee as chair of the peer review committee and as vice chief of the department. Dr. Lisa Zuckerwise is maternal fetal medicine specialist in Nashville, Tennessee, and has over 6 years of experience in the medical field. She is a graduate of Albert Einstein College of Medicine and did her residency at Yale New Haven Hospital and a fellowship also at Yale. She is a maternal fetal specialist, and my understanding is Frank hired you and brought you to Nashville. That's my understanding.
Correct.
I will also just say that the medical professionals, all of the doctors here, are representing their own view, their own experience of what the law has been doing and how it's affected their practice. They do not represent the views of their hospitals. So with that, I will ask Dr. Zuckerwise if you'll just sort of set the stage for our conversation and tell us a little bit about basic information about abortion and reproductive health.
Sure. So I'm tasked with defining what is an abortion. And we would think that this is a pretty simple concept or pretty straightforward. And it actually is. It's quite scientific. An abortion is the ending of a pregnancy. It can happen spontaneously. A spontaneous abortion is also called a miscarriage, where a pregnancy that once was there spontaneously ends. What we're here to talk about, though, more directly, is an induced abortion, an abortion that occurs as a result of either medication or a surgical or other procedure to interrupt a pregnancy. And I think at its core, the term abortion, it's important to know limitations. It does not talk about how a pregnancy was conceived. It does not talk about where in a body a pregnancy was conceived. And it does not talk about whether the pregnancy can actually result in a live born child. It is simply the ending of any pregnancy.
Follow up from Dr. Bohm or Dr. Lipsitz on that?
Well, the definition that we used for many years at Vanderbilt, and I think still is a good one, is abortion is a procedure with the intent to deliver a dead fetus. That was the simplest way to describe it. And it was something that was done before fetus achieved a stage of viability, which today is 22 weeks. Used to be, when Roe v. Wade was passed, was up to 27 weeks. But with modern medicine techniques, it's now about 22 weeks. So keep that in mind as the definition. The new state law has redefined it, and it's a little bit more complicated. I'm sure we'll talk about that.
Yes, we'll get there. Thank you. So Dr. Lipsitz, what is the difference between a medical abortion and the morning after pill? And in our planning, you mentioned that some of your gynecological patients, there may be some concern even using a IUD under the new law. How has the law already affected access to contraceptive care and other family planning options? And are you concerned that perhaps all contraception could be banned?
So there's a big difference between medication abortion and the morning after pill. Medication abortion consists of two medications, mifepristone and misoprostol, and those are medications that you take when you're pregnant and your intention is to end a pregnancy. The morning after pill is what you take to prevent a pregnancy. So they're very different, but people have a lot of confusion about them. The morning after pill can be taken if you are not using contraception, if a condom breaks, if you are forgetting to take a lot of your pills, if there's sexual assault, but the intent is to prevent a pregnancy. There are several different types of emergency contraception. There is a prescription pill called Ella. There's an over-the-counter pill called Plan B or levonorgestrel. You can also take kind of a concoction of birth control pills that you have at home. And you can also have an IUD placed as emergency contraception. The pills that are prescribed or you can get over the counter, those are best if taken within 24 hours, but you can take them anywhere from 70 to 120 hours after unprotected sex. The pills work by preventing ovulation or delaying ovulation. We usually recommend that somebody takes a pregnancy test before they take the morning after pill. But if somebody is already pregnant or they don't know they're pregnant and they take the morning after pill, it does not affect that pregnancy. And so the morning after pill, if you're already pregnant, does not cause an abortion. If you're already pregnant and you take the morning after pill, it does not harm that pregnancy. But this is where some of the controversy lies, is that many people think that the morning after pill causes an abortion. So the current trigger ban does not ban the morning after pill, but there is some valid concern as our legislative bodies become more conservative, but they're going to limit those. And the morning after pill, unfortunately, is not 100% effective at preventing pregnancy. So our main goal these days has been to make sure that people have birth control if they want it. And when we're talking about the IUDs also are not affected by the current trigger ban, but there is also concern that when we see more and more legislation that these may be limited as well. And there's also some confusion about IUDs because many people think that they cause abortion as well. So there's some thinking that there could be a post-fertilization effect. So you have a conception in a tube and the fertilized egg travels to the uterus and can't implant and is effectively passed or expelled. And people think that the IUD causes an abortion. And this has been looked at with studies. They've looked with human studies, animal studies. They've done super sensitive blood tests for pregnancies. They've done flushing studies where they've looked for eggs and fertilized eggs in the uterus. And no studies have ever shown that IUDs cause abortion. But again, this is where the confusion is. And so there are some people who really are firm believers that IUDs cause abortions, but they don't. And so we are seeing in our practice, a lot of people who are calling and very worried. We spend a lot more time these days talking about contraception and whether it's still going to be legal or not. I'm definitely putting in more IUDs than I did before. I'm also seeing many more people call and ask for permanent contraception. I'm having people come and say that their doctor would not tie their tubes or remove their tubes because either they weren't a certain age or they didn't have a certain number of children. And none of this is true. But people are being told this. And I've had more than a handful of women tell me this. So I am seeing this kind of insidious erosion of women's autonomy over their bodies, even beyond the abortion issues, that people are being given wrong information. So if someone comes and they want to have their tubes tied, yes, I have a long discussion with them and talk about their medical history, make sure they're aware of other options, other long-acting options. I tell them about studies, that would increase the risk of regret. But people are adults and they need to be able to make decisions about their bodies. And I am seeing some changes that women are not being given correct information. And so we do need to continue to make sure that IUDs and Plan B are not vilified or that access becomes limited. And we do need to make sure that contraception is publicly funded and insurance continues to cover it. So we still have a lot of work to do, even beyond the abortion issues.
Any other follow-up on that?
Well, I'd like to say that what Dr. said was extremely important, because you'll be reading in the newspapers that the morning after pill and IUDs in particular cause abortions. They don't. And what we're trying to do is prevent pregnancies. 50% of pregnancies in this country are unintended. 50%. And 40% of that 50% are the ones that have abortions. So if you can prevent unintended pregnancies, you can significantly reduce the number of abortions performed in this country. And as a matter of fact, when Obamacare was passed, it made contraception more available at a cheaper price. And the number of abortions went from around 1.3 million, used to be 1.5, went from 1.3 million to the latest count of 862,000. And if we really push contraception, like the IUD is 99.7% effective. It wasn't that way when I was practicing many years ago, but extremely effective. So if you are supportive of getting rid of abortions, the best way to do that is to have contraception readily available. I'd make it free for women of reproductive age, personally. But if it's the very people who seem to be the most against abortion who are also against contraception, and that never made any sense to me. Never made any sense at all. This is a wonderful way, but the information you just heard from Dr. Lipsitz is extremely important, because in Tennessee today, we're stuck. We're really stuck at the moment. We've got a real problem. And one way out, not all the way out, but one way out is to prevent unintended pregnancies. And that means sex education, and it means available contraception.
Thank you. And for those of you both in the room and viewing, we hope you'll help spread the word about that. It is a very important piece of information. There's been a lot of misinformation about it, so please help spread the correct information about that. Dr. Zuckerwise, in your practice, you serve high-risk patients. Could you tell us a little bit what makes up a pregnancy high risk as opposed to a regular pregnancy?
Yeah, and there's a lot of things that can make a pregnancy high risk. I think in this discussion and in this climate, it's really important to understand that while Dr. Bowe mentioned that the vast majority of pregnancies are who undergo abortion are really early and unplanned pregnancies, just about 90% are in the first trimester. The patients that I see desiring pregnancy are those who potentially conceived very desired pregnancies, potentially conceived pregnancies that were planned and long awaited, and something drastic changed to make the pregnancy unhealthy. And so the minority of pregnancies that find their way to me of women who are seeking abortion are those who have medical complications of the mother or the pregnant person that threaten their health. And they might not know that their health is threatened until those changes of pregnancy come about. And that's not typically until the second trimester. So I think this is really important right now as we have certain people proposing, 15 weeks is the magic number after which anyone who wants an abortion should have gotten one. What that doesn't account for is that a pregnant person with really severe hypertension or a pregnant person with out of control diabetes or progressing cancer might not have physiologic changes or changes to their body that results from pregnancy that shows up until the second trimester. And that's not going to happen until, 15 weeks is just after the end of the first trimester. So it's not going to be apparent that this pregnancy might be actively threatening their lives, risking their livelihood, risking that they might die, risking that they might develop progressive cancer, become severely impaired by a stroke, or have any number of really catastrophic events from maternal health. We might not know about that until 18 to 20 weeks. So that's maternal complications. And that's one side of the spectrum. Something that I deal with a lot or take care of a lot, my focus of my clinical practice is fetal anomalies. And so patients coming for fetal diagnosis, learning at their anatomy scan, that doesn't reasonably happen until 18 to 20 weeks, that this loved, desired, and celebrated fetus inside of them has a structural or chromosomal difference that will not allow them to result in a healthy or even live child. And so these patients come, and they're a minority, but they're a really powerful minority when these pregnant people are being asked to endure the changes of pregnancy, endure the risks that are associated with childbirth. And if we're being honest, our country, for all the resources that we have, does a pretty poor job of taking care of pregnant people in terms of preventing harm and death at baseline. So even a young, healthy person carrying a pregnancy that won't result in a child needs the right to say, this is not worth risking my life for to me. In the same way that another patient might say, this is worth risking my life for to me, and then allow us in that exam room to walk them through both of those paths. And then the third high risk component is the obstetric component. The pregnancy itself can cause life-threatening conditions to our patients, can place them at really high risk for major bodily harm, serious infections, septic infections, needing to lose their uteruses, hemorrhage or bleeding to death, things that are so horrible once they happen. But fortunately, as physicians trained in high-risk obstetrics, like Dr. Bohm and myself, and also physicians who take care of patients in pregnancy on a daily basis, like Dr. Lipsitz, we see patients who break their water in the second trimester, who are at risk for life-threatening infections and bleeding. We see patients with abnormalities of the placenta that cause their blood pressure to skyrocket or cause the placenta to adhere too tightly to their uterus. That specific condition, placenta accreta, carries a 7% risk of that person dying as a result of pregnancy, and nearly a 100% risk of a hysterectomy. And so if we can diagnose this early in pregnancy and counsel them on that, I don't know anyone that would say lining up 100 pregnant people, 100 mothers in families, and say that 7 of them shouldn't have the right to choose whether they continue this pregnancy or don't. So that was a kind of long-winded, what is high risk? There's a lot more to it.
And I think to echo your point, that this talk of the 15-week ban, that I see in my practice low risk and high risk pregnant people, and many people are very healthy, and then they find out at their 20-week anatomy ultrasound that they have a pregnancy with a severe complication. So that 15-week is arbitrary and really inhumane, because we don't know until later some of the time, unfortunately.
So we've heard some of those stories in other states where women, unfortunately, the fetus is no longer alive and they've been sent home rather than being able to perform an abortion. Is that already happening here?
So I think what we're seeing is in the state of Tennessee, as hopefully everyone understands, there is absolutely no exception in our law. Every single abortion that is performed, whether it's a medication abortion or a surgical abortion, is illegal. We as physicians, in doing this procedure, whether it's saving someone's life, whether it's interrupting a pregnancy that's desired but not viable, we are committing a felony. We can use the affirmative defense, we can justify what we're doing, and the law provides some verbiage, provides some examples of what the lawmakers in their non-medical terms have deemed likely to be good excuses for breaking this law. But we are always committing a crime when we perform an abortion.
So this is a question that feeds into one of the questions we had already been thinking about. So how are residents going to gain enough training in Tennessee to be OBGYN doctors without the ability to perform abortions in their residency? So this one was going to be for Dr. Bohm, as you've had experience both before and after the Roe decision, and also deeply engaged in Vanderbilt medical training for many, many years. What do you see as how that's going to affect the training in the state?
Well, it'll affect it. I don't think it's going to be a huge problem. When I finished my residency, I started my residency, it was in 1965. And it was a time before Roe v. Wade. So I never learned anything about how to do an abortion, but I learned how to do techniques that were used in abortion. And over the years, we just learned how to do things. It wasn't that terribly difficult. Medication now is a big part of abortions, and the surgical procedures of D&C and D&E procedures that you haven't heard much about, that we all learned how to do, really wasn't that difficult as long as you had some training. And by some training, I mean having some experience. And I think what we're going to have to do at Vanderbilt, I don't know, Lisa, you may know this, is that we're going to have to send our residents to states where they are trained. Our residents at Vanderbilt used to go over to Planned Parenthood to get their training, or I would train them in the operating room at Vanderbilt. But now we're going to have to send them somewhere, and I suppose we're doing that now.
There's definitely talks in all academic institutions in this state of how we're going to train our learners. I think right now, the other thing that is not really being discussed by lawmakers and by people who aren't seeing what's going to happen down the line is that we're in this sweet spot where we all know how to do abortion safely. We all know what to do if a patient comes in hemorrhaging, septic, and needs a life-threatening abortion. I know how to do the procedure safely, even in an emergent situation and even under extreme stress in an unstable and critically ill patient. What I worry about is when 10 years from now, I'm no longer the first person, the first line of defense, and there are people who trained in these circumstances, who stayed in these states, having very sparse access to abortion care. And then patients are coming in emergent situations. And then there aren't, I'll be an old timer, maybe then, I'll be older. And I won't be around to just run in and take every opportunity to help or to train. And I think what we're setting ourselves up for in the future is a period when not only is abortion illegal, but no one knows how to do it in these unicorn affirmative defense cases that are still going to exist. And so right now, what I say, the other thing is that it's very hard when, as someone who has a leadership role in one of our training programs, it's hard to try to convince people to come and train in a state like ours. It's scary to practice medicine in a state where you're at risk of needing to commit a felony in order to prevent someone from dying. We all go into medicine, and obstetrics especially, knowing that the risk of litigation from malpractice is always there. We accept that. We are a very risk tolerant group. We accept that risk of malpractice litigation because what it is trying to do is keep patients safe. It's the reason it exists is so that we all have the patient's best interest of practicing safe, effective, and evidence-based medicine to take excellent patient care. But now we're throwing in the risk of legal threat that is completely antagonistic to patient care. It's making patient care unsafe. And so I worry down the line how we're even going to get people to come and train in our state. And we are, to your question, Dr. Baum, we are working to find places that we can send residents so that they can get hands-on training for a period of time in their residency, so they can learn these skills and bring them home with us. And honestly, if we're lucky, the residents who get those skills, some of them will be brave enough, committed enough, or something enough to stay in practice in our states that are putting, doctors against the law.
Before Roe v. Wade was passed, abortions occurred, and they'll occur after Roe v. Wade was turned over. As a young man, I was 27 years old, and I was admitting patients into our emergency rooms with abortions that were botched abortions. We didn't have medications, but the coat hanger type abortion. And it really made an impression on me. I was only a young man when a 21-year-old senior at Yale came in with one of these back alley abortions and got infected. And we did a hysterectomy and took out her ovaries. 21 years old. She was from Greenwich, Connecticut. I'll never forget it. Her parents were very wealthy and were just flabbergasted that this happened. And yet we didn't have the antibiotics that we have today, and she became septic and died of an infection of her heart valves. And I realized then we had to do something. And what really worries me about the Tennessee law, and by the way, Tennessee and Idaho are the strictest.
Right.
Help me, Jim.
Two most strict.
Restrictive.
Most
Most
restrictive,
restrictive, right,
thank you.
right.
I have my English teacher here. Are the two most restrictive states in the country. You are not allowed to do an abortion even to save the life of a mother. Forget rape and incest. Forget those. The life of a mother, you can't do one. And if you do, you are setting yourself up for a possible felony. We never thought a nurse could be indicted and taken to court. And yet the Vanderbilt nurse was indicted and found guilty because she caused a patient of hers to die. This was unheard of. Malpractice, we understood. Losing your license, we understood. But going to prison is not something that we understand. So I'm very worried about the life and health of patients who are going to have abortions. Make no mistake about it. The fact that it's outlawed is not going to stop it. Go to South America where it's outlawed all over the country, all these Latin countries. They still have 1.5 million abortions every year. And they run into the very same problems that we're having. We have a serious problem in the state of Tennessee. And part of me is glad I'm retired, but I'm glad we've got good people like sitting to the left of me to do the work.
So that sort of brings us to another audience question. What's the guidance that you're getting from your hospitals where you do have privileges? How are you being advised by the hospitals where you work?
I'd say that's a bit of a loaded question.
And you do
because
not
that-
have to answer anything
No,
that you don't
I
want
mean,
to.
I can speak in vague terms that I would, from my knowledge, I'm not sure that any of the hospitals in town has put anything in writing, I suspect, for liability issues. I'd say the word on the street is that we continue to take care of patients when they're sick and do the right thing as we've been doing. And the onus is really on us to document and to really be very careful about how we document. So if one of the examples you had given, so if somebody is 15 weeks and their water breaks and they have an infection and they needed an abortion to prevent sepsis, then that patient is not liable. So if she's having an abortion to save her health, she cannot be criminalized. What we have to do is to document. We need to document why this is necessary. We need to have another physician agree in writing. We need to specifically say, in my best judgment, this is why this needs to happen to help save either prevent death or prevent severe injury to bodily organs. So again, the hospitals, I would say, are not necessarily making widespread statements.
Yeah,
Yeah.
I would say that's pretty accurate. And in that example, it's a perfect example of that we practice in the same town in different institutions. And we are told, and the messaging, which I think is so important and I genuinely believe in, is that we continue to take excellent evidence-based and when necessary life-saving care of our patients. And that has not changed. The thing that has changed is that we do it within the confines of the law, and the law has obviously changed. And so to that example of a patient who breaks her water early. When you break your water, that bag of water that's around the baby that has a barrier, those membranes prevent infection from getting into the uterus. Once that water is broken, that barrier is no longer there. And so you can have a really severe, really quick, before you even know that something's happening, a raging infection inside a pregnant uterus, which really is acutely life-threatening. And I don't doubt that my institution and that the legal community would agree that a patient with a very obvious, active, life-threatening infection is someone who warrants an abortion. But my question is, what about the time leading up to this grave situation? What about the time before that patient is in the ICU requiring medication to keep her blood pressure safe? What about the time before that patient is requiring a life-saving hysterectomy in the setting of a raging infection? What about just when her heart rate elevates and that's the first sign? What about when the fetal heart rate elevates and there's the second sign? But neither of those signs in themselves are overtly dangerous. Neither of those signs say that anyone is about to die, but they tell me, someone who's seen this multiple times, that in the next 24, 48, maybe 3 days, this patient is going to develop a clinically significant infection. And so if I can say that at that point, is that enough to say that an abortion is warranted? And I honestly don't know. I've not been told the answer to that question. These questions are on a case-by-case basis, is my understanding, the guidance I've gotten. And all of us are left when they say, of course you can save someone's life. Of course you can act in the moment. And that's all fine and good, but as a high-risk OB, my job is to say, what's the worst thing that could possibly happen next? And how do I not get there? Not how do I get there and then fix it? I want to not get there at all. And I think that that's the problem with this law, and the problem that it was written by non-medical people, that there's no way to clarify it.
So this sort of follows to that. It's a question regarding maternal mortality rate. And many of us have read that the rates are increasing actually in our country. And the question is, where does Tennessee stand in those rates? Where are we in terms of maternal mortality?
I mean, we do know that states that have the most strict abortion bans also have the highest maternal mortality rates, unfortunately. So we're not in a great situation with our maternal mortality rates.
Not great, agree.
Yeah.
There's another, so here's a question about, unfortunately, this isn't even the case here because in our law, it's banned from the time of conception, but there's a question about the fetal heartbeat. When does this actually happen, and how does this relate to the states that do have heartbeat laws?
Well, it's always been a bit of a misnomer because you will usually see electrical activity or heartbeat between 5 and 6 weeks, but most people don't know they're pregnant until after that. So for the states that have a heartbeat ban, or what we had until the end of June, until the end of August, where you could have an abortion up until 6 weeks or before a heartbeat was there. I mean, that's a very narrow window, and many people don't know they're pregnant then. So it's not even though abortion may be allowed early on, most people don't know they're pregnant at that point.
Keep in mind that a pregnancy is usually called in terms of 40 weeks, but 2 of those weeks, the first 2, you're really not pregnant. You don't have any evidence of pregnancy. There may be fertilization, but it has to roll down the tube and get into the uterus and implant and then deposit its hormone, human chorionic gonadotropin, into the bloodstream. So when we say 6 weeks, the fetus has implanted only for 4 weeks, and women don't know they're pregnant. And the only way you can really tell is to use an ultrasound machine, and we can pick up fetal heartbeats very early, 6 weeks, without any problem. So the 6 weeks ban is basically a total ban on abortion.
And historically, the limitations were quickening, or when the woman feels her baby move, that would be a sign of life. And that preceded any ultrasound ability to detect it. And then we got big chunky TV screen ultrasounds that just look like black and white snowstorms. And maybe at 15, 20 weeks, you could see a heartbeat. It's really unfortunate that we're being punished for having such great technology and innovation in the medical field, that our ultrasound probes have such a high frequency and such good resolution that we can even detect electrical activity. It's not a heart beating, it's cells in a tube just kind of moving, that we can detect it as early as 5 to 6 weeks. It's really valuable to start interventions in patients who need them, people who need medications to keep the pregnancy going, people who need medications to prevent them from having complications like blood clots, that we need to start right away. It's great that we can detect pregnancy early, but it's just really unfortunate that it's also kind of a catch-22 of, if we didn't know, we'd have more time.
So in terms of how the pregnancy proceeds, there's also a condition in which it's an ectopic pregnancy. And so Dr. Lipsitz, would you explain what that is and how this law will affect the treatment for that?
So an ectopic pregnancy is a pregnancy that implants outside of the uterus, most typically in the fallopian tube, but it can also occur in the ovary, in a cesarean section scar, in the cervix, or in the abdomen. It occurs about 2% of all pregnancies. An ectopic pregnancy will never result in a live baby, except on Grey's Anatomy, where I did see that on Grey's Anatomy. But an ectopic pregnancy can be treated with medication or surgery, and rarely just observation, but not very often. And when an ectopic pregnancy grows, it can be very dangerous. It can grow in the fallopian tube, it can rupture, it can cause bleeding internally, and in some cases, it can lead to death. So the question is an ectopic pregnancy part of the Tennessee abortion ban? And some of that may be up to debate, but if you look at the definition of abortion and how they define conception, it does fall under the bill in most views, unfortunately. And to be honest, I had never considered treating an ectopic pregnancy as performing an abortion. And when we started meeting with our attorneys in June, and they said, hey, ectopic is part of this, and I was like, wait, what? So something I do on a fairly regular basis is now a felony? And I just could not believe it, because again, you're never going to have a viable pregnancy. And I have spoken at a couple forums, and I have assured people that they would be treated in a timely manner. And I still firmly believe they will be treated in a timely manner. And I have treated several people with ectopic pregnancies, from June through the end of August. I have not had any people since the trigger ban went into effect, but it was business as usual. Somebody was sick, they needed surgery. Nobody sat around scratching their heads. We brought them to surgery and they were taken care of. However, I did meet a woman last week, and she did ask me to share her story and gave me permission to share her story. And she is a young woman, a mother of 2 children. She got an IUD this summer just because she was scared of everything that was going on. She had pain a couple of weeks ago. She thought she had appendicitis, and she went to an emergency room at a local hospital here. They did a pregnancy test and she found out she was pregnant. And her first thought was, I have an ectopic pregnancy, and will I be cared for? And frankly, she was terrified. And she had an ultrasound that did show that she had an ectopic pregnancy. And it also showed that there was blood in her pelvis and that the ectopic was starting to rupture. The doctors did meet with her, and they told her that they had to talk to legal. And then there was a delay. There was about an 1.5 to 2 hour delay. And then they came back and said, we've spoken with legal, we can take you to surgery. And in those 2 hours, her blood count did go down. So there was more bleeding. They brought her to surgery, and unfortunately she was fine. But these delays, are not always fine. Sometimes people have to have a more extensive surgery. Sometimes they need blood transfusions. Sometimes they have to spend time in the ICU. So these delays are really important. And in this woman's case, they did not need to speak with legal. She needed to go right to surgery. So we do have some work to do. We need to continue to talk to doctors about the fact that they need to take care of the patients. And not taking care of somebody in an emergency like this is a violation of the hospital's EMTALA laws, which is the Emergency Medical Treatment and Labor Act, where somebody's acutely ill, you have to take care of them. And also not taking care of somebody urgently in this situation is a violation of our standard of care. So we are, in these situations, people need to be taken care of. So we do need to continue to educate people about the bill. We need to, I mean, this woman, not much was in her control, but we need to encourage people to continually advocate for themselves. And we need to make sure that ectopic is treated as an exception when the legislature comes back. So there's a lot that we do need to do, about
This
ectopics.
law violates the 4 basic principles of medical ethics. Beneficence to do good, non-maleficence to refrain from doing harm are 2 of the 4. And we violate it by not taking care of the patient. It's a real travesty.
And I think that we're among the lucky ones. We're in a big city that's really replete with medical care, medical facilities, access to colleagues that we can message on various apps all the time. People, we can phone a friend at any time and say, what have you done in this situation? What I feel for in hearing your story is, what about the patient in a rural area in this state who has scared physicians trying to do their best, but don't have access to the legal expertise, the academic expertise, and are just trying on a day-to-day basis to follow the law, go home to their families, not end up in jail and not let people die. And then you add into the mix people with poor medical literacy, people who can't advocate for themselves, people who don't speak English and can't interface, already have that barrier interfacing with the healthcare system. And it's just compounding the harm we're doing to populations that can't even begin to understand how atrocious this law is to them and how it's going to impact their health.
So Dr. Zuckerwise, this is sort of a bit of a follow-up to that. So in your work with high-risk pregnancies, you're often working with a medical team. It's not just you, there's a whole team of people. And as you described, there can be different thoughts on different things. How is this law affecting the team approach to those cases?
That's such a good question. And I'd love to say that we're all on the same team. And I'd say for the most part, we're all team patient. We're all for, again, providing the most evidence-based care to the standard of care, even exceeding the standard of care to save lives and take great care of our patients. And that is the team that we all are on. I will say that with all teams, certain people tend to rise to occasions and certain people tend to back away from fights. And it's, this concept of risk tolerance, this concept of, who can stand by and wait and, and who can't. I don't know what's right or wrong. If, someone who says I am risk tolerant and I will do anything in the patient's best interest, if they end up in prison, they are no longer serving the community. They are no longer serving their oath. They are no longer serving their patients. So it really is a balancing act. But what I will say is that it does often feel that the people who are expected to care more, who are expected to run to the fire, the high-risk OBs, the people who have been in practice for longer, the senior emergency medicine physicians, the ones who are not in training, who've been doing this, who know how bad it can be, we're the ones being called in when our colleagues say, I just don't feel comfortable. And to them, we respond. So it's more okay for me to put myself at legal risk for my young children to have a mother in jail than it is for yours, because I am more comfortable with this or more defiant or more opposed to it. So I think it creates a really dangerous team dynamic where we all should be doing the same thing. And we need exceptions. We need to be told this is a yes, this is a yes, this is a no, according to the law. And the only way that could happen is if the law is written by medical professionals who understand the nuances of medicine.
And then also, if you're in a situation where you need a full team, you need a nurse anesthetist, you need nurses, you need anesthesiologists, you need medical technicians. And if somebody's not comfortable and you're in a small location, then you're stuck. And it would be nice to have a network of hospitals where, say, if you're a patient in that situation, you're not getting care, you can come to us. But I don't think any of the hospitals in our communities are going to want to be seen as the go-to place in this situation. So it is very scary that you only have a certain number of staff in smaller hospitals. And if they're not comfortable, going forward, then people really will be at risk.
I have a question. We've talked a lot about, you checked with legal before we did anything. Legal means attorneys that are hired from the hospital. That has nothing to do with state prosecutors, the attorney generals. And I would think, and I'm retired now, so I don't have to worry about that, but the two of you obviously do. The legal tells me it's okay, but if I've got a attorney general that wants to indict me, like they indicted a nurse, I've got to go through that. Now,
Yeah.
Vanderbilt, I understand, indemnifies, they'll pay for all the expenses, but they can't keep you out of jail.
Yeah.
And I'm not sure that I trust the legal system in Tennessee to not want to indict some wonderful obstetrician gynecologist just to get a political plus on their chart. So
Yeah.
it really worries me.
Mhm.
What sayeth you about that, Lisa?
And I think it's such a big question. And it's a really important one. And I know a lot of us in this room struggle with this on a daily basis. I think the first problem is that when we say we consult with legal, the legal teams in place in hospitals are malpractice legal experts. My legal team that I'm working with is really good at telling me how to document when an outcome was different than that which I expected, which, to be honest, I've already done. And I've already acknowledged that things can go differently in medicine and that we perform the standard of care at least and above. When it's criminal law, they are not experts. It would be the equivalent of asking me to do spine surgery. I can't. I've seen it once or twice. And so when we say we're consulting with legal, we're just using the resources we have, the best resources we have in that time, which honestly, to someone on the front lines, feel insufficient at best. And so I will say that we do feel legally exposed. And yes, some employers have offered indemnification, have offered to pay for your legal fees. But what I haven't seen in writing, and I don't know if other employers have done this, is what happens when we're going through that process. Are those vacation days or those unpaid work days to people who support their families, to those of us whose families are on our health insurance? Are we being covered during that time for health insurance and benefits? What is happening throughout this whole legal process? And as we in obstetrics are, again, always thinking, what's the best outcome? But really, what are we trying to prevent from happening? I think our minds are going there as well. In what if we are that test case? What if we are that sacrificial lamb that gets tried to see how far these prosecutors actually going to take it? What happens to us and to our livelihood and to our family and to our communities during that time? And will the trust and the support of our employers, will it hold up or will it let us down? And we don't know. We hope it'll hold up. That's my answer. I'm still here.
This is a sort of variation on that legal question, which is if Vanderbilt begins sending doctors to other states for the training, is there potential risk of liability or criminal charges for that? In other words, sending a doctor to do something that in this state would be illegal. Has there been any, in terms of the medical schools, not any concern about that, at least at this point?
Right. The way the law is written right now, to my understanding, and correct me if I'm wrong, is that it's when a physician, so again, it's not even like any provider who could do this historically. It's when a physician performs an abortion, that physician is liable. And so what happened within the state of Tennessee? So as long as they are appropriately credentialed, licensed, approved to practice medicine in another state, it's not in that jurisdiction and it's currently safe. Now, who knows what's going to come down the pike in terms of traveling, or right now we can advise patients, we can counsel them, we could help them set up appointments out of state. I don't know what's going to happen if that changes. I know in Texas, for example, aiding and abetting is a
Mhm.
crime. And so there's the question if, physicians can even advise, can even reach out and make calls, or if we literally just have to put shoe cards in bathrooms in our clinics. Shoe cards are little things that you can slide in your shoe to hide from people who
So-
shouldn't see them.
So this is a follow-up for Dr. Lipsitz that's sort of related. So if one of your current patients or friends presented to you that her 15-year-old daughter had been who was not sexually active, not previously sexually active, and not on birth control, and was raped by a boy in her school, and she's now pregnant. The new law would require them to go out of law for the abortion. How would you advise them? Where would you be sending them? And what would it look like if they wanted to access a medical abortion?
There was a case in Florida of a 16-year-old who was seeking an abortion, and the state of Florida declared that she was not mature enough to make that decision to have an abortion, but she was mature enough to raise a child. So for this person you're talking about, I would first express my rage and sympathy and make sure they had legal resources, psychological resources, and then ask what their plans were. If she's planning to have an abortion, I would first advise her not to go to a CPC or crisis pregnancy center. And those are clinics around the country. There's some in Nashville and Tennessee that are clinics that masquerade as full clinics, but their goal is to convince people to continue their pregnancies. So you do have to be careful with the crisis pregnancy centers. And then if she is planning to have an abortion, there's a couple of things to think about. I can give them resources. At this moment in time, I'm allowed to talk to her about anything. I can tell her about Planned Parenthood. I can tell her about abortionfinder.org. I cannot really pick up the phone and make an appointment for her. I would be concerned that that would be somehow facilitating a crime or felony. I can give her resources. If she's interested in a medical abortion, I cannot prescribe medication for her. At this point in time, if she were to receive medications in the mail, she would not be liable. Starting in January 2023, it will be illegal for physicians out of state to send medication abortions to her, and that's the telemedicine abortion law. If she were to leave the state, this is my current understanding, if she were to leave the state and have a medication abortion, even if she brought back some of the medication, she would not be criminalized at this point. If she goes out of state by herself, she would not be criminalized. There is no punishment or criminality for somebody to seek an abortion out of state. The issue is if she brings a parent or a friend, then that parent or friend could have what I believe is called criminal responsibility, and the extent of how that would be enforced, I don't know. I'm not an attorney, but you do have to be careful. And certainly one thing we're worried about is new legislation being enacted over time that would prohibit people from leaving the state. How that would be enforced, I don't know. There is more talk about, just online, and I've had patient questions about something called SMA or self-managed abortions. And that is where people obtain the medication, the abortion medications on their own and take them. And as clinicians, we do need to be aware that we're going to have questions about it. And I've already had some questions about it. Again, we have free speech. We can answer people's questions about it. We also there's no Tennessee law that if somebody comes to me and says, hey, I'm planning a self-managed abortion, I have no responsibility or duty to report her, and I would not. And a lot of the self-managed medication abortions are actually fairly, very safe. People follow the same protocols that the Planned Parenthoods give out. This is a little bit of a controversial topic because I don't know how many gynecologists here in Tennessee are comfortable talking to their patients about that. And there are some countries, you mentioned that in some countries where they realized a fair amount of their maternal mortality was increasing because so people were performing home abortions with toxic substances or instruments. And so in order to decrease their maternal mortality, they started a program for harm reduction. So a patient could come to a doctor, see if she was a candidate for a self-managed abortion. Did she have any risk factors for an ectopic pregnancy? Had she had an ectopic pregnancy before? Was she too far along? Just to see if she was a candidate. And then the patient would go and get the medication on her own and then come back for follow-up to make sure that it was completed and that there were no complications. And in these harm reduction clinics, they did see a significant drop in mortality and complications. Again, this is a hot topic, I know, but we are going to see more questions about this. We're also going to see more people come into our emergency rooms with bleeding or infections, like you mentioned, and you mentioned that if somebody comes into the emergency room and says, I'm pregnant and I'm bleeding, it could be from a home abortion. It could be from a miscarriage. To be honest, we don't need to know the backstory. We maybe even shouldn't know the backstory. What we need to do is take care of the patient. But a lot of us, and I've been doing this a long time, we still haven't taken care of many people with septic abortions. I mean, that's been many years and few and far between. But this is something we're going to have to know how to do because we will see people, but it's not something we see commonly. But if somebody comes in bleeding from any type of pregnancy, they deserve to be treated with care and respect. Nobody needs to know how they got here, what happened beforehand. But there could be some controversy at some hospitals here in town or in the rural areas. I don't know. But we worry about people's safety. We worry about people not coming in because they think they're going to be prosecuted. So there's such a windfall effect of all of this that hasn't been thought of and is very dangerous.
So this is, I'll give this to you, Dr. Lipsitz also. Is it true, this is an audience question, is it true meds used to soften the cervix to make IUD inserts less painful have banned because it's used in abortions? And are there other medications that are used for abortion that have that are also used for other treatments that could be banned because they could also be used for abortions?
So the two medications used for medical abortion are mifepristone and misoprostol or Cytotec. So the Cytotec or misoprostol is used, we use it in OBGYN a fair amount. So we use it when we're inducing somebody in labor. We use it if somebody has a fetal demise and we're inducing. We use it sometimes before a GYN procedure called a hysteroscopy to soften the cervix. And sometimes when putting in an IUD, we'll have somebody take it beforehand. And then we also use it when people have a miscarriage. So, and we'll actually give both of those medications when somebody has a miscarriage. We have had some instances where we have prescribed misoprostol or Cytotec for management of miscarriage or before an IUD placement, where pharmacists have said, I always tell people that pharmacists may say something that's not quite right, but you have the right to get this medication. They have to dispense the medication. What I'm personally doing now is writing on the prescription what it's for and the medical diagnosis. And I tell the patient, I'm writing the reason. Is that okay with you? Because I don't want to violate their privacy. But on the other hand, I don't want them to be in a situation where the pharmacist won't dispense it. Mm-hmm. So yes, there are stories you'll hear a pharmacist not dispensing, but the medication is available. We're starting to actually stock it in our office to avoid some of these possible complications, but there's not any alternatives, to be honest, no great alternatives.
Another audience question. I've heard the morning after pill has weight limitations. Is this true? And if so, what options do people have if you're above that weight limit?
So the morning after pill, the one that's over the counter, levonorgestrel, is less effective if your body mass index is over 30, and even in the 25 to 30 range, it may be less effective. There was a recent study that looked at, hey, can we just double up on it? Will that help, ensure the efficacy of preventing pregnancy? But increasing the dose has not been shown to help. So there is some concern. You can still take it if you're in that body mass index range, but it may be less effective. The prescription pill, Ella or ulipristal acetate, is a progesterone receptor modulator. So it works in a slightly different way. And that is a little bit better if people are at a higher body mass index.
Any other follow-up on that?
Also, the Paragard IUD as a postcoital contraception is not body mass index dependent. So it's the copper non-hormonal IUD that can be placed within 5 days of unprotected sex and can prevent pregnancy and implantation, and then also used for 10 years of contraception as a side effect.
Yeah, and it's actually the most effective form of emergency contraception, but it's not one that people commonly think of or use as much.
This is getting back a little bit to the hospital question and concern about hospitals that might be purchased by Catholic agencies and how that, what the interference might be with contraception, pregnancy, and delivery. I'll throw that open to whoever wants to try that one.
Yeah, I mean, I practice, one of the places I practice is a faith-based hospital. And so we have practiced in some ways, kind of almost according to the trigger bill for a while. So if somebody's water breaks and they have an infection, if they have an infection and they're sick, we do value the life of the mother, and we go ahead and perform abortions or terminate in these situations. So those are not outlawed. We sometimes will involve an ethics committee. We will usually have 2 physicians agree that it's necessary. In terms of birth control at a Catholic hospital, we use birth control for many reasons these days to treat heavy bleeding. So if you have a medical reason, also taking the tubes out has been shown to help prevent ovarian cancer. So we have a little bit of a workaround, but there are medical reasons to use birth control, and that is all permitted.
I think the problem has been is that the standard of care regionally. And when you're talking about the legal aspect, and I am not a lawyer and I don't have very much experience with them, thankfully. But when you're talking about that, is that Dr. Lipset says that in her institution, if that water breaking is an obvious infection, obviously threatening the life of the mother, then they can go ahead and deliver. If I'm at a not faith-based hospital that interprets the rules a little bit differently, am I then and safer, might I add, in patients who desire ending that pregnancy? Am I exposing myself because not only am I potentially not practicing within the law, but I'm not even practicing within the region of what people are doing? So I think there is a trickle down effect, and that this has come to us already, that we look to. One of my colleagues is former military, and their health insurance does not cover abortion care. And so in cases of rupture of membranes, they did have to wait for overt infection in their military hospitals in order to proceed. And so she's kind of walking us through what it looks like. And so if that is, at a federal situation or in someone at a Catholic hospital, if these are what people are doing, that really does trickle out to affect all of us, regardless of whether we're at a faith-based hospital or not, and make our administrators or those advising us, our legal teams, our ethics teams, our medical leadership say, I don't know if that's okay. But, when it was legal, we were cool with it. But now that we don't know if it's legal, probably we should be as conservative in interpreting the law to save our staff as we can, which is not the best medicine.
The new law has made all hospitals, I don't want to use the word faith-based because it's not in Jewish law. So I'd have to say it's Christian. Vanderbilt now practices the same kind of medicine as far as abortion is concerned as St. Thomas did when I was in practice. So we're all in the same boat now, but it's I don't think we should use the word faith-based.
Yeah, I mean, part of what we do for patients has been taken away, because previously if somebody's water broke at 15, 17, whatever weeks pre-viability, the prognosis is dismal. Even if you don't have an infection, you need that fluid for the lungs to develop. And so before the trigger ban, we would give the patient an option, tell them, the baby's lungs aren't going to develop. You can choose. You can go ahead and have an abortion, or you can wait. But now we don't have the option, and the patient has to sit around waiting for an infection.
And we doctors who have spent our lives trying to help people really take this very seriously. It becomes an emotional issue. Give you an example. With our ultrasound now, we can make a diagnosis very early of serious problems like anencephaly. Anencephaly is a condition where a child, it's a severe neural tube defect, sort of like spina bifida, but it's all the way at the top of the head, and there's no bones covering the brain. 100% of these children die after birth. They may live a day or a week, but they all die. There's no chance of life. But we can't touch them now. And so this means that these women, and I've seen this happen before, are then subjected to the problems of preeclampsia, high blood pressure, or severe diabetes during pregnancies, or postpartum hemorrhage, or pulmonary embolism, all the things that can happen in pregnancy. Because we're not taking the mother into consideration, we've created an incredible problem when we diagnose fetal heart abnormalities, hypoplastic hearts, for example, which we do a wonderful job of making that diagnosis. And we can offer abortion to some women. Some women will say, well, we want to go ahead with the pregnancy, and the child will then have 3 operations in the first few years of life with a certain amount of mortality. We take all those decisions away from people because they no longer are being taken care of by people who practice in anything but a more of a Christian based practice, as we used to see in Catholic hospitals throughout this country.
This is an audience question that sort of relates. I'm not certain that this had to do with it being a Catholic hospital at all, but the question says, I'm a DES baby and went into full labor at 16 weeks. We were at the beach and no doctor on staff would examine me. We waited 3 hours for a private OB to come treat me. Why? How would a patient today receive care if having premature or life-threatening labor?
Well, I'm super sorry to whoever that happened to and for that situation. I think that it speaks to everything that we're talking about, that you get what you get when you show up to a medical facility. I promise you, if you're in my exam room, I'm taking care of you immediately. I know my colleagues and people I've spoken to around here feel similarly. However, we don't know what the vast majority of physicians feel. We don't know what they've been made to feel. We don't know what their administrations are telling them. We don't know how they're interpreting the laws. We don't know how their legal teams are advising them. We don't know how their religious leaders are advising them. And I think that every single patient is going to be affected by this. Every single person who has female reproductive organs is going to be affected by this. And we don't know how. And it's hard to know to what point it's going to have to get before the lawmakers understand that this can affect them as well. It's not, those of us who have resources, those of us with medical literacy, those of us with friends in the medical field. Yes, in most situations, we can advocate for ourselves. We can travel, we can seek help, we can seek care, we can seek a private physician. And so by far and away, the people who are going to be affected by this are those without resources and without means. But that's not to say that someone on vacation is not traveling somewhere, that they find themselves in a situation being cared for by a team that does not share our values or that does not have the resources available or the advocacy. And I think this is going to happen everywhere. It's going to happen at every level. And it's really unfortunate. And it's probably only going to get worse with time as like-minded people seek out like-minded places and leave people behind in, the more restrictive situations. I also, I have a colleague who told me, she texted me the other day. I trained at Yale. I was in the Northeast, which is a safe state for abortion care. And one of my former mentors texted me, something happened today that I never thought would happen. I advised my patient not to travel to Tennessee in pregnancy. And I told her, no, at 22 weeks, you can't go there because what if something happens? And that really, really affected me. And as OBGYNs, we travel for conferences, we travel to take our boards. Our trainees are expected to travel, to fly to Texas every time they have to take an oral board exam. What are we doing to our pregnant trainees, requiring them to travel to a state that is not pregnant person friendly? Are we really willing to put them? Yeah, are we really willing to put them at risk? The Society for Maternal Fetal Medicine, SMFM, who's our governing body of maternal fetal medicine specialists, actually moved their annual conference from Florida to San Francisco this year because they didn't, they didn't want to make us travel to a place that was so hostile to reproductive health. And I'm hopeful that, the same thing will happen when we have things planned in Texas, but I don't know. And then we can't leave our colleagues behind in Texas and our patients behind in Texas or Tennessee. It's a really slippery slope. It's really hard.
Yeah, and that also happened with the American Board of OBGYN. When you take your oral boards, it's 3 hours at a hotel room in Texas. So people coming up for their boards recently had a petition, and then they ended up, it was going to be the first in-person oral boards in 3 years, but the American Board said, we're not taking you to Texas, there could be liability. So it became virtual again.
So this is more of a comment, but relates to what you're saying, which it's just so sad to me. I'm afraid to get pregnant in Tennessee. What if I have an unhealthy pregnancy? And as a bit of a follow-up, is there any other aspect of healthcare regulated to this extent? Are there other significant healthcare laws that ignore medical science?
No.
I can't think of one.
No.
I can't think of
No.
one.
I mean, I spend a lot of time. I have very healthy people who are thinking about pregnancy, who are terrified to become pregnant. And I have people who have high risk conditions who are even more terrified to become pregnant. So this is a very common question, a very common cause of concern. They have lots of questions about what if, will you take care of me? What will happen? And so it's a big fear, and this stress has an impact on people.
A lot of different problems. 50% of physicians are female, but 80–90% of obstetricians, gynecologists are female. It's going to be hard to bring them to Nashville, to Vanderbilt, to St. Thomas. This is going to have unintended consequences that we can only just speculate at this point, but it's going to definitely affect the kind of care that we're going to be able to administer in the state.
So we've got a couple of questions that sort of relate to Jewish law. I'm going to address them to the doctors, but luckily we have some rabbis in the room as well, so we may have to ask a rabbi. The first is related to there is a pending lawsuit in Florida that I believe was brought by a congregation, a conservative congregation, basically suing as a piece of personal religious freedom that the law violated their Jewish belief, and it was a violation of Jewish law. And as we learned in our first session, it is. And so I'll open it to the doctors, and if not, I'll see if the rabbis have any more information about that case.
Well, there is a form that if we perform an abortion, we have to fill out a form that is supposed to go to the Office of Vital Records. So if that's something I do in my office, if I treat somebody with an ectopic, I'm supposed to fill that out. And then if something happens at a hospital, a termination for medical reason, the hospital fills that out. I was concerned, and I looked at the form. I said, is there any place on this form where I have to say, I agree that pregnancy, that everything begins right at conception? And there's no place on that form. But the suit in Florida is that, again, in Judaism, we don't believe that everything begins right at conception. And I'll defer to the rabbis in the room with more information.
And for those that weren't at the first session, it is online and you can watch it, but if you want to just give a follow-up.
There are different. The question is when conception happens, or when life begins in Jewish law, and there are several different interpretations based on timing. But the truth is that the idea of a woman being the primary source of where we're going to focus our attention, the life that is, rather than the potential life. So there are some ideas that of ensoulment happening earlier in gestation, but what we really don't focus on that as much, because the life until it comes forth is not considered a full potential or a full life with the same rights or needs as the mother that is, or the female who is carrying that child. So it is a violation of our understanding of when life begins. And that makes all of these laws really in contradiction to how we believe people should be treated in their healthcare.
Don't go away. We have one more that we may need the rabbi for. And this sort of gets to what you were saying about defects in which the baby would not be able to live. As doctors are facing criminal charges for terminating a pregnancy in the case of a fetal anomaly, which would violate Jewish law to give birth, knowing if the birth defects, knowing if with that sort of a birth defect, do you feel a doctor could defend pregnancy termination if the parents are both practicing Reform Jews? So it's a bit medical and a bit, right, because it would be, in Jewish law, it would be definitely permissible, absolutely permissible to terminate. Expect, in fact, required, right, right.
So I don't know who asked this question, but there was a comment that unless it was an Orthodox Jew, it wouldn't, the same law, the protections wouldn't apply. So I think there's a little bit of an underlying question here, is that if it's a Reform Jew versus an Orthodox or a more traditional Jew being considered for this, because if we don't observe some of the other laws, why would this one then sort of be our standing point? Oh, and in Orthodoxy across the spectrum, all of us would say that termination is necessary to uphold Jewish law. But I think the question also has inside of it, you know, if they're not Torah observant Jews entirely, how can they use this as a defense?
Well, the example in Exodus would indicate that it's the exact opposite of the Tennessee state law. Because in Exodus, it says when two men fight and a woman is injured and loses her pregnancy, the assailants have to pay the husband for the child that was lost. But if the woman dies, then they're to be put to death. So there really is no fetal right in Jewish law. And if you take a look at the Talmud, they say that once the greater part of a child is born, you may not touch it. Well, that means partial birth abortion, for example, which was finally, thank goodness, outlawed for a good reason. But that would indicate that life really doesn't begin until a child is, the major part of a child is already out of the vaginal canal. So the Jewish law and what we're faced with in Tennessee are total opposites.
Thank you. One more sort of related Jewish question before we move, and because I want to make sure everyone has a chance for closing comments. In addition to Tay-Sachs, are there other, for European Jews, are there other pre-pregnancy testing that should be done for parents?
I mean, I will say that Tay-Sachs is a great example of a condition that is tragic and more highly associated with Ashkenazi heritage. But there are a lot of other recessive conditions. And what recessive means is that if the female partner and the male partner have it, when they come together to conceive, there's a 25% chance that both of the affected genes go to that fetus, and that the child would be affected with the disease. If only one parent contributes the affected gene, then the child is a carrier but is not affected. And so Tay-Sachs is a perfect example, but there are a whole lot of other metabolic and other genetic diseases that you can be tested for. So to answer that question, there are really great carrier testing panels that test for hundreds of autosomal recessive conditions, and many of which have the Ashkenazi component, all of which do, because this is kind of where they all started, but that they contain a whole host of different autosomal recessive conditions. that it does benefit us to assess before we conceive or shortly thereafter, so that we can offer testing of the pregnancy. Even better in a state like Tennessee, if you do find that a couple are both carriers of a genetic condition, there's an option to do something called IVF with PGT, which is in vitro fertilization, where you actually test the embryo to make sure that you're implanting a healthy, not affected embryo. We haven't talked about IVF and embryos, and if conception happens in a test tube, does conception happen at all?
We're going to address that a little bit in the next session.
Yeah, and I will say that it's really not right now, but it is a slippery slope. But the short answer is there are panels that have hundreds of genes. And so something that we don't often think about as a Jewish population is like cystic fibrosis affects 1 in 24, or 1 in 24 of us will be carriers. So that is probably one of the most common autosomal recessive conditions that's screened for. And so definitely come see a genetic counselor.
Thank you. So in closing, I want to allow each one of you the opportunity, if you could speak directly to those who wrote and enacted the Human Protection Act, which is what they're actually calling the current law is called the Human Protection Act. What are the 3 most important issues you would want them to know about in terms of how it is impacting patient care?
I would say, I mean, first, I think we need to talk about the trauma of this all. With the Kansas bill, one of their slogans was care for them both. And if you think about a pregnant person who's carrying a fetus that's not going to survive once it's born, she has to go to work. She goes to the grocery store. We live in the South and people want to talk to you in the grocery store. They ask if you're having a boy or girl. They ask if you have a name. They want to touch your belly. And these are all fine things, but we're not caring for them both. We're really not caring for anyone. And we're creating a long-lasting trauma in this person. And it is, as doctors, we are trained to not abandon people in times of need. And in this situation, because I cannot offer an abortion if that's what the person wants, I am really being forced to abandon her. And I'm calling that state mandated patient abandonment. So we can't do right for our patients. And then another thing is a lot of, if I care for somebody with an ectopic pregnancy, if I care for somebody whose water is broken and they have sepsis, I am committing a crime. And there's no other option. There's no other medical treatment in these situations. And so they have rendered what is evidence-based, appropriate standard of care practice into a felony. And it's still mind-boggling to me. How can that be? It just makes no sense. And that we really, like you said, need to think about who is going to move here and practice in this environment. Who's going to care for our relatives, our children? It's a real deal breaker as an OBGYN to think about moving here to practice. And I do think we're going to see some attrition. And then lastly, I know this may be fruitless, but I would ask the legislatures to think about the long-lasting impact on people who are denied abortions. There was a very large and well-done study called the Turnaway Study, where they looked over a decade of people who were denied abortion compared to others who were able to obtain abortions. And the people who were denied abortions really had long-lasting impact on their health, on their finances, on their mental health. And in that study, there was actually more maternal mortality than they expected, which was alarming. And also their children also had developmental psychological impact as well. So this is seeking an abortion is not a point in time or an isolated event, but for people who seek it, they don't take it lightly, and it has downstream long-lasting impact on people's health and well-being. And it's a very important study to look at.
It's hard to, this is the first time that I'm like publicly speaking about this. And I think what took me so long is that it's such an important topic that it's a lot of pressure to do it justice and how it impacts us on a daily basis. Even though I haven't done this before, my husband who's in here will let you know that I talk about it essentially 99% of my waking hours because it's really consuming. And so what I would like the lawmakers to know is that people who take care of pregnant people, those of us who help usher in healthy life, those of us who break terrible news to people who have all the hope of a healthy pregnancy, and those of us who are facing the possibility of a pregnant woman carrying a child dying in our hands, do not take this lightly. And I'm not supposed to say anything super morbid because I know it can be offensive, but I just want to mention this term that really gets me. And I think about every time I think about how sick is too sick, that anyone would agree with me that there's no question that an abortion was indicated. And this term we talk about in obstetrics of audible bleeding, which is when a patient is bleeding so heavily and so briskly that you can hear it from the doorway and you know what's happening. And that is something that is so haunting that we prevent it at every opportunity. And so what I would say to these lawmakers is, let us help you. Let us help you understand what we're up against. Let us assume that we're all in the right place. Assume that we went into medicine to do right by our patients, to protect your mothers, the doorway to your family, to build your legacy, to give us the benefit of the doubt that that's what we're in it for. And that these rare events where we have to do something that is so charged as an abortion is a hard decision every single time, whether it's an unplanned pregnancy, whether it's a doomed pregnancy, whether it's a dangerous pregnancy, it never comes about lightly. It's always a really big decision. So let's just all kind of get on the same page and agree that we all want to protect humans. We all want to protect lives. We all want to, build this happy and healthy and fruitful society. Let us do our jobs and take care of people medically, and kind of stay out of it. And, let us educate you and let us take care of you and let us take care of your daughters. Let us take care of your wives. Let us take care of your mothers. But just kind of trust that we're doing the best we can and you're really impeding it. Is that an answer?
Yes.
Well, I would hate to follow that, but I'm going to. You see why I was so happy to bring Lisa from Yale to Nashville. It was very well said from both of you. The only thing that I would say, it's sort of been said already, is I would say to the lawmakers, there are a lot of pro-life obstetrician gynecologists, well-intended, intelligent individuals who I would hope they would at least consult to bring up this issue of there is two patients. And I've never met a physician who was just pro-life, who didn't understand all the medical things that we're talking about and could have been used when the law was being made. We've really taken the pendulum and swung it all the way over. Because when I was a young physician and practicing for all those years, the criticism I heard from my colleagues who were basically pro-life would say, look, there's another individual involved. There's a fetus. We need to consider the fetus. And it's a good argument. And it's hard to counter. And we've taken this pendulum and we swung it all the way over to now we're ignoring the mother, which is just astounding to me. And I think had these legislators consulted some of the individuals in the business who were not pro-choice, but who were more of the ilk of pro-life, they would have explained to these lawmakers the very kind of things that we were talking about. Well, you got to carve out the ectopic pregnancies, and you got to carve out the septic abortions, and you've got to do this and that. It would have been such a wonderful thing if they could have at least done that. But the way it is now, we in Tennessee are in serious trouble. And I really feel bad. I started in this business before Roe v. Wade. As a matter of fact, I wrote a column for the Tennessean. It's been almost about a year ago now. And it was very widely accepted and I got a lot of calls. Everybody loved it. The title of it was Why Roe v. Wade Will Not Be Overturned. And so nobody was more surprised than me, I think, because it flies spread it exponentially. We've got to change the law. We've got to make exceptions. We cannot put the Nancy Lipsitz and the Lisa Zuckerweisses in harm's way, because when they do an abortion, they are in harm's way, and they are at the mercy of some aggressive attorney general or prosecutor who will use that as a case to further their career. We've got to do something. And all of you in this room, now that you're educated, can help us in this mission.
I would like to echo that. Thank you for coming and being online. Yeah.
And let us also thank our panelists, our expert panelists, Dr. Lisa Zucker-Wise, Dr. Nancy Lipsitz, Dr. Frank Bohm. Thank you so much for helping us to learn together and to then take it out and share it with others so everyone has a better understanding of just what we are facing in the state in this moment. Thank you. We will continue to learn together on November the 14th at 7 o'clock. That one will relate to some of the issues mentioned here that we didn't have time to cover. So if you'll join us again, we'll have more information on November 14th. Thank you to the Temple for hosting us this evening. And thank you to all of our community partners who have helped us put these programs together. Cherith Israel Congregation, National Council of Jewish Women, the Gordon JCC, West End Synagogue, Moishe House, East Side Tribe, Congregation Micah, Jewish Family Services, Chabad of Nashville, and Hadassah. As far as I know, these series have been the first time that every single Jewish organization in our community has worked together. And I believe it is because it is such a life, it's just truly a life and death situation. And so we thank you all for being with us, and we hope to see you again on the 14th. Thank you.
We do. Like I said, we Okay. Yeah.